Good afternoon, everybody. I'm Dr. Aniruddha. I am Senior Resident in the Center of Addiction Medicine. Today, I'll be presenting about cannabis-induced disorder. Initially, I will be giving an introduction and clinical aspects. Then I will go to neurobiology, the clinical features, and finally the management and the controversies in this of cannabis-induced disorders. Now, cannabis, as we know, has been a very ancient and in ancient times has been used in different civilizations. In Indian civilization, as we know, in fact, today is a very appropriate day probably for discussing about cannabis. Today being the Shivratri. In Shivratri and around this time, cannabis has been used in India for centuries. In fact, the Vedas also contain references to cannabis. Not only the Vedas, the Chinese ancient pharmacopoeia, it also says about some medicinal aspects of cannabis. Not to mention about the Babylonian and the Assyrian civilization, from where probably the etymological origin of the word cannabis was there. From the ancient time down to the medieval ages, cannabis was equally prevalent. We find writings, reference of cannabis in the writings of Marco Polo, who had traveled widely across the world in medieval times. Down to this present, down to the last century, 21st to the 20th century, where we find the reference of, where we find cannabis used very prevalent even in spiritual sects like the Rastafari sect, which flourished in Europe, and US in 1940s, and also obviously the Hollywood and the culture who had at times promoted cannabis use. Briefly, the historical aspects. This is the social, from the social use to the core scientific aspects of this cannabis. Is though it was used for centuries, the active ingredients was discovered in 1964 when the delta-8 tetrahydrocannabinol was found. But not until 1990 was the endocannabinoid system, the anandamide, they were discovered. And thereafter, within a span of few years, numerous interesting discoveries were made until in 2006, rimonabant was approved in Europe for weight loss, which acted on cannabinoid receptor. But thereafter, it was banned due to some troublesome side effects. Now, what is this cannabis? This plant, this cannabis, it was named as early as 1753 by the father of taxonomy, Carl Linnaeus. And though he named cannabis sativa, thereafter they have been found that in different parts of the world, different genus prevail. Like this cannabis, probably which is not that visible, but cannabis indica and cannabis rudolfensis, these are the different varieties which have different combination of THC and other psychoactive substances in cannabis, like the tetrahydro, like the cannabinol and the cannabidiol. And these often lead to differences in physiological and psychological effects in the people who take them. Now, the different.
One second, Aniruddha. Can everybody hear us? Okay, no, I think, okay. Go ahead.
The cannabis is a plant which is often grown in dry, arid areas, and from different parts of the plant, different products are available. Like fresh leaves and stalk, we get the bhang, there, and also from the leaves and the dried stem, often we get a ganja. Hashish, we get from the resin, and the extracted from the resin, extracted by organic solvents, we get the hashish oil. They have different amounts of the active chemical, the tetrahydrocannabinol, like from bhang, it may be 2 to 5%, to the hashish oil, which can be even 20 to 30%. And even newer techniques are trying to enhance the amount of the psychoactive substances in cannabis. For example, in 1980s, it used to be the psychoactive substance in cannabis plants and derived from cannabis plants used to be average, it used to be 2 to 5%. Now it has gone up to 12%. So we can understand how the psychoactive properties are being enhanced. And one type of farming is known as the Sinsimela type of farming, where they preferentially grow the female plants which yield more potent tetrahydrocannabinol and more potent cannabis. Now, as in the previous case we saw this cannabis one can intake the cannabis in different forms, like the chillum pipes, the bongs, or some vaporizers. These depend upon the parts and the people who are taking it. But overall, in our country, chillum probably is the commonest. Now coming to the synthetic cannabinoids. Synthetic cannabinoids, these have been in vogue for the last 1 decade or so. Actually, it is the product of search for potent cannabinoids which can be used for medicinal purposes. Clemford University, one researcher, Dr. John Huffman, he did cannabinoids. The synthetic cannabinoids, they are designed for not for human consumption, but are taking the advantage that they cannot be screened easily in by standard tests, and also they are easily available in web, and also the fact that they are inexpensive compared to in some parts of the world, in some countries where good cannabis is quite expensive, they flourish. And currently they are one of the very common in some parts of the world, like Taiwan or China, like the latest World Drug Report says, they are creating havoc, and they can create significant psychotic symptoms. Often those psychotic symptoms are very resistant to treatment. Now coming to the epidemiology of this cannabis use. Cannabis, as you know, see from this World Drug Report of 2013, is very prevalent. India luckily is in between. If we can see the, of course, India is in between, neither too prevalent, but the prevalence in India as per the National Household Survey is 3%. But of late, cannabis use has been increasing, particularly in the urban areas among the adolescents and youth. Cannabis use has been using tremendously. That has been seen in a recent 2013 report among adolescents and youths. I have not included the data. Now the active ingredients of cannabis, as we have just discussed, that THC is an active component. Apart from THC, there are around actually by pyrolysis around 60 chemicals are found, of which THC is the most psychoactive. Apart from that, there are the cannabidiol. Cannabidiol has significant antipsychotic properties, and in some forms it may be used in medicine in future. But whatever it might be, the components are numerous, and often it is difficult to find the exact composition of from which strain from which the cannabis determines what are the chemicals that will be found. Now coming to the pharmacokinetics. Pharmacokinetics, one of the very striking properties of tetrahydrocannabinol is the high lipophilicity. Because of the lipophilicity, it preferentially distributes to the adipose tissue, and it quickly to the liver, lung, and spleen. The bioavailability is 30% for heavy users. This I'm saying of this inhalation use. The oral use, as we see in the graph, the oral use, the bioavailability is quite less, and it takes time. So in inhalational use, within few minutes, it takes quite a good number is delivered to the body. Though only 1% is delivered to the brain, but that amount is sufficient for one to get intoxicated. As we have seen, the half-life, because of the pharmacological properties, the half-life depends on on whether the person is a frequent user or a chronic user. For frequent user, it is 1.3 days, and for chronic users, it may be 5 to 7 days. This has tremendous implication for our clinical understanding and for toxicological analysis. We will see that in occasional users, cannabis are found for few days. However, for chronic users, cannabis in their body excreta like urine or other samples, cannabis can be present for a few months altogether. Now the metabolism, it is metabolized in the liver by the cytochrome P450. There are both hydroxylation and the glucuronidation. This THC-11 carboxylate, it is a active ingredient which can help in detection of the cannabis. Now coming to neurobiology. The common neurobiological reward circuitry, as has been discussed quite often, is that from the ventral tegmental area to the nucleus accumbens, in the nucleus accumbens, dopamine is being secreted. and this gives rise to a high, and the person, because of the reinforcing effects of the dopamine, the person continues to take substances. Now, this release of dopamine is mediated by different neurotransmitter systems like the glutamate, like the GABAergic system, um, um, and, 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 and there are other neurotransmitters also. Ca- Cannabinoids, particularly this tetrahydrocannabinol, can facilitate or inhibit or alter the processes. As we can see in the red mark at circles, that in the different interfaces in the synapses, they play a very vital role. Now, coming to more molecular aspects, if the tetrahydrocannabinol is there, there may be some receptors, how they are working. So, rat animal models, this is a animal, this is a picture of a radioligand binding studies of animal brain, where it has been seen that there are the distribution of the receptors. There are two types of receptors have been found mostly, the cannabinoid receptor 1 and cannabinoid receptor 2. The cannabinoid receptor 1, it is widely distributed, but most commonly in the basal ganglia and the cerebellum. It is mostly presynaptic, and it regulates the activity of, as I have said, it regulates the activity of the other neurotransmitter systems. The CB2 receptor, it is mostly found in the immune cells and regulates the immune system. Now, if the receptors are there, there must be some ligands which are endogenously produced and which activate the system. These are later research has found that these are part of the endocannabinoid system. The first one to be discovered was anandamide. This is derived from the Latin word, from the Sanskrit word anandam, which is very very known to us for the eternal bliss which often cannabis produces. Others, they are the two arachidonic and the glutamine. Now, now probably it will not be, this picture might not be clear very much, but one thing that I like to convey that these are manufactured locally within the cell membrane, and there is no elaborate synaptic pathways or the vesicles where they are secreted. So if you are not able to visible or understand this detailed process, you can please remember that this anandamide, they act in a retrograde fashion, that is from the post synaptic process to the presynaptic process. There is no storage in the synapses. There is no synthesis in the cytosol. They are they are synthesized then and there, and they are also degraded there. These degradation methods may be pathways, maybe modalities for development of future pharmacological treatments. And also there is rapid breakdown and local action is there. Now coming to the nosological status. Cannabis use disorder, as we have said, this is a word which is actually given by DSM-5, but the dependence properties and the dependence criteria, it was for cannabis. It was unlike the other dependence producing substances like alcohol or tobacco, because classical withdrawal symptoms, at one time it was believed that classical withdrawal symptoms, they were not producing. So it was more defined as part of the because of its salience and this because of this salience and this preoccupation with use. But later research has shown that withdrawal symptoms are also present. Now, these cannabis use disorders, as per this is DSM-5, there are 11 criteria, of which at least 2 of the 11 criteria should be satisfied to diagnose as cannabis use disorders, and there are very varying grades of severity. Like if either 2 to 3 symptoms mild can be there, there are 4 to 5 symptoms moderate, and 6 or more it may be severe. Now, this cannabis withdrawal may be precipitated in a person who is taking heavy cannabis use and there is sudden cessation, and it may start after 2 to 3 days after cessation of cannabis, and it may continue till 1 to 2 weeks. The symptoms are irritability, anger or aggression, nervousness, sleep difficulty, decreased appetite or weight loss, restlessness, depressed mood, abdominal pain, shakes, tremors, etc. Now, clinical features. So, cannabis use is typically seen in a young adolescent who starts because of experimentation. Initially, it may be give a high and relaxation. Most commonly in a study done in 1980s, it was seen that most commonly adolescents would report of relaxation and relaxation and some euphoria out of that. Thereafter, however, most of the people do not go for dependence. Studies have shown that only 9%, even less than 10%, go for dependence. The predictors of dependence are definitely environmental factors, availability are there. Apart from the genetic factors associated mental illness, the early onset of substance use. The earlier the onset of substance use, the greater the likelihood is the person will go to dependence. In fact, it has been said that cannabis was the gateway hypothesis was classically propounded for cannabis, that people who use cannabis had a higher propensity to proceed to other harder substances like heroin or cocaine. Now, the clinical typology, there basically, it has been said that there are two types of cannabis users. One is the type 1 who use cannabis very frequently and who had difficulty giving up and severe withdrawal symptoms, and who then themselves come for their treatment. Type 2 are the less severe, who take once in 2 days, who can be treated in occasional urine testing. Now, signs of cannabis intoxication. People like residents who are often in the emergency room find people coming with cannabis intoxication. They may have euphoria, significant perceptual disturbances. They may complain of feeling of unreality. They may have a sense of time slowing down. This is very characteristic of cannabis. There may be vivid colors like also synesthesia and other subtle symptoms like decreased mental performance, increased appetite, and analgesia may be there. This is one of the saying in the famous journal psychiatry BMJ. It appeared that how a person had described himself by his own words, his experiences. Now, cannabis, particularly chronic cannabis use, have some medical consequences. One is if I would enumerate them system-wise, one is the ocular system. We know that cannabis cannabis has decreased in intraocular pressure, and also there are some ocular injection and some conjunctivitis may be there, but long-term problems has not been reported. In terms of cardiovascular and the respiratory system, also there are changes. For respiratory system, for example, for the acute user, in the experimental situation, there is bronchodilation. But for the chronic user, particularly who is using with tobacco, there are reported definite reports of increased bronchitis and tuberculosis. There has been some reports that even chances of cancer, particularly from animal studies, that cancer might be there, but this has not been that much substantiated in large-scale epidemiological studies. Now, coming to the cognition and higher mental function, and in the acute user, there are some cognitive disturbances. Yes, but for the chronic users, there are some cognitive disturbances, though it is not so gross like the alcohol user. But for the chronic cannabis user, there are some subtle problems, particularly executive dysfunctions, motor speed, that give rise to problems during driving. Apart from this, there are subtle other problems in reproductive system and immune system which are not that much substantiated. Now, psychological effects, as we have said that psychological effects, there are psychological effects like some mood symptoms, some anxiety symptoms, and in high doses, in particularly in people who have started using early with positive history, there might be development of chronic psychosis. We had dealt with this topic in an earlier presentation, so I am not going into details. One thing only I would like to say that for the vulnerable individual, starting early cannabis is definitely a risk factor for cannabis that has been proved in large epidemiological studies. So here I have just summarized the clinical effects, like there is impaired short-term memory, impaired judgment. This impaired judgment is very important for the clinical period because often with the impaired judgment, there may be high-risk behaviors by adolescents giving rise to numerous problems. Often this altered brain development may lead to long-term consequences like poor educational outcome, decreased life satisfaction, leading to overall leading to overall poor quality of life. However, though compared to other substances like alcohol and tobacco, however, there has not been an increase in mortality in long definite results of increase in mortality in epidemiological studies in people who use cannabis for a long time. Now coming to management, management-wise, first as far as the clinical, as far as the clinical document and the clinical skills is after detailed history and physical examination, we go for laboratory analysis. Laboratory analysis is though theoretically though textbooks say that it can be done in saliva, hair, nails, blood, and urine. In common day-to-day practice, we usually use urine. Urine tests can be done by two methods. One is the immunoassay, the single kit or the poly kits, which are bedside tests, which are very handy and they immediately can know about the test. Other more definite is the chromatography. In chromatography, there are two types. One is the gas and the liquid. The liquid is more sophisticated, more sensitive and specific, but these are costly investigations only available in few centers. The cutoff for detection of cannabinoids is 50 nanogram per ml. This is a standard international regulation. Now, another important thing is duration of detection in female. As I have said, because of the lipophilicity and the pharmacokinetic properties, for single user it is 3 days, but for the moderate and chronic users it may be more, and for chronic heavy users it may be more than a month. Now coming to the definite treatment of this cannabis, the different modalities of treatment agencies which we have are the agonist, which is synthetic THC, which is dronabinol. Then there may be the inverse, agonist, or there may be the neuromodulators. We have a good list of them. We will see how much they act or what are their efficacy. First, coming to the treatment of intoxication. Intoxication does not warrant much aggressive pharmacological intervention. Only some symptomatic propranolol, benzodiazepine, antipsychotics may be helpful. Rimonabant has also been used, but it has been banned of late of the side effects. Now, treatment of withdrawal. It is important because of the withdrawal symptoms, often patients are not willing for treatment, and to retain them in treatment, we need to treat the withdrawals. Also, all medications have been tried, from agonists like oral tetrahydrocannabinol to lofexidine, which is a clonidine like an agonist of alpha-2 receptor, to baclofen, benzodiazepine, lithium, of which the largest study has been the largest randomized controlled trial where there was a combination of lofexidine and dronabinol. It has proved that it is efficacious, and dronabinol in the long term is also safe and better tolerated, though we are not sure of how effective they are in reducing cannabis use, in reducing cannabis, particularly abstinence. Though definitely some improvement is there in improving the outcome, like heavy use days, or improving the functionality, but definite improvement, but definite abstinence, hence efficacy in definite abstinence is still not that much convincing. This list shows a long list of like from N-acetylcysteine to entacapone, buspirone, fluoxetine, naltrexone, on dronabinol and rimonabant. Of this, the study with N-acetylcysteine, it has been is a very good conducted RCT, and in that study, it has been published in 2012 American Journal of Psychiatry. In the study, there has been improvement in self-report, though on verification with the with the pharmacological parameter, it has been found that biological parameter, it has been found that it was as not corroborating. Though we know the controversies with the methodological issues in corroborating the findings with the biochemical parameters. For these reasons, probably no medication has been approved by any regulatory authority. Most reduce withdrawal symptoms, improve retention, but not a significant effect on abstinence. So the recommendation is a judicious combination of pharmacotherapy, and not to forget of the psychosocial intervention, particularly motivational enhancement and cognitive behavioral therapy, family interventions, and contingency management. For the sake of brevity of this presentation, I am not covering simply psychosocial intervention, but they are equally important or probably more important than the pharmacological measures in the management of cannabis use. Now there are some newer newer direction what the treatments which may be used in future are inhibitors. We have seen that how the fatty acid metabolism, some enzymes, they can be inhibited for alteration of the endocannabinoid pathways. We can also the second generation cannabinoid antagonists are also being developed. Dronabinol, we need more research, though it is a promising data, but we need larger studies to comment on its efficacy and to comment on its tolerability. The nicotine alpha-7 receptor antagonist may also be useful. And also another interesting way of treating the cannabinoid, because it is seen that people who use cannabis, they often they lack some social cognition, and studies have been there which have tried to improve with oxytocin. Now, medical marijuana. As I have said that in the beginning of my presentation, that from time immemorial, cannabis was part of the pharmacopoeia. So it has been used in recent past for some illnesses, and in fact, it has been approved of late by different pharmacological agency of different countries, like dronabinol, which is a pure isomer of this delta 9 THC, and also nabilon, which is a synthetic oral analog of THC. They has been used for treating nausea and vomiting in cancer chemotherapy and the chronic wasting syndrome of HIV and AIDS. Also, this nabiximol, which is a patented mouth spray, an oral analog, which has been used for multiple sclerosis. This nabiximol is a 1:1 and 1:1 combination of THC and cannabidiol, and it has been approved in some European countries for the treatment of this spasticity of multiple sclerosis. Apart from that, there are also less well-confirmed clinical effects, spasticity due to spinal cord injury, different pain, bronchodilation, glaucoma. It is being used, and it may be used in future in epilepsy and alcohol dependence. And basic research is considering its use in a good number of conditions. Now, as we have discussed, as per recommendations, and it is seen that buspirone in doses up to 60 mg is a reasonable first choice. In fact, it is said that in these guidelines published by Indian clinical practice guidelines published by Indian Psychiatric Society, where where the levels of evidence are organized as A, B, C, D. A being the most robust, as being data derived from meta-analysis and robustly conducted RCTs, to D, which where it is mostly by consensus as agreement. It has been seen that the highest grade of evidence is for buspirone on fluoxetine and entacapone. Fluoxetine and entacapone has also been advocated. Baclofen, though in many of the centers, including our, we are using, but it is also a treatment option. And N-acetylcysteine, of course, which data is coming of late, is also has been included in the C option, but it is also recent studies are quite promising, and those studies had not been probably covered in this clinical practicing guidelines. So in future, this N-acetylcysteine, baclofen may come up as more promising agents. So we have seen the uncertainties, which I would like to summarize, that would give a headway for young researchers in conducting research in this area, which we need more pharmacotherapy for management of cannabis withdrawal. What are the risks and benefits of short-term hypnotic prescribing? Often we prescribe benzodiazepines or zolpidem for treatment of this cannabis withdrawal, which needs to be more researched. The role of cannabinoid receptor-specific agents, and the one unresearched area in this field, which I have not covered in details, is the treatment with comorbid mental illnesses like schizophrenia or bipolar, in which cannabis is very common, and also the role of medication is given to relapse. There is some evidence in the acute treatment of cannabis and its related condition, but what is the role of the medication in preventing relapse? How much it is efficacious? That also needs to be studied. And lastly, as it has becoming, you have ending by one quote by this is one famous Brazilian psychopharmacologist who has been he was so much this is cannabis that it is for the few drugs, this tetrahydrocannabinol, which have pervaded all the civilizations and all the total toxicologies and dependence inducing effects.
Thank you. Thank you. We have already some questions. I'll read out two. One is from Dr. Pfizer, who asks whether there's any evidence of varenicline in the reducing craving or promoting abstinence for cannabis. And Dr. Sauradas has a question. He's asked any prospects for nabiximol.
First of all, I would like to take up the question of varenicline. Varenicline, as I have said in one of the slides, it is posted as an experimental mode of treatment. I think practically RCTs or any sort of evidence practically is not there. Experimental mode of therapy to decrease the cognitive, particularly the cognitive dysfunction, and to target the cholinergic pathway, it has been used. And nabiximol has been, like I have said, like I have presented in my presentation, nabiximol has been actually approved by some European agencies for treatment of the spasticity of multiple sclerosis. But still, it is US FDA and many other government authorities have not still approved it. But in some countries, it is approved.
We have a question from Dr. Banerjee. He's asking whether that cannabis-induced psychosis is talked about quite a bit, but how frequent is cannabis-induced depression? He's also said that nabiximol is, as you've said, is used as a spray and is still in trials for multiple sclerosis and neuropathic pain and bladder relief.
Cannabis, depression, cannabis-induced affective changes, like I have said in one of the slides, that basically the anxiety symptoms and mood symptoms, they are more probably common than these psychotic symptoms, but they are not that much dysfunction producing or that not that much chronic compared to this psychotic symptoms. But definitely cannabis-induced mood disorder is a entity and it has been also recognized by our nosological systems.
Dr. Sauradas clarified as to whether nabiximol has any role in cannabis withdrawal.
Nabiximol is supposed to have some role because it is a combination of the agonists, agonist and antagonist, also mostly combination of agonists. But I'm not sure. I have to look into studies whether it has been studied in the cannabis withdrawal study for amelioration of cannabis withdrawal symptoms.
Any more questions? We can still take some from the house.
Okay, I had one clarification. This 2012 study, there were two studies. One is open label in which urine samples were not included. The second is actually a double-blind controlled RCT. The primary endpoint was number of urine samples in 12 weeks, which came out to be negative, and odds ratio was 2. So it was a fairly well-designed study. And as of now, in contemporary trials, and there's a trial by name Accent, which is evaluating N-acetylcysteine at almost 2.4 grams per day. It's a National Institute of Drug sponsored trial. That is one thing. The other thing is the Cochrane review in 2010 actually didn't consider studies on buspirone because all of them were overwhelmingly negative. So, I mean, I'm not sure that how does it qualify as grade A evidence in our guidelines.
I have mentioned these discrepancies in our guideline. Like currently, more evidence is coming in favor of N-acetylcysteine. So if they review the guidelines, N-acetylcysteine may go up the ladder. And buspirone, as you have said, that some instances are in favor of this buspirone, but Cochrane review is to that extent.
The only thing about N-acetylcysteine would be, as point out, the dose would need to be right.
Yes,
you need to be between 2000 to 3000 mg to actually achieve any difference.
In that study, they used up to 1800, but in clinical practice, it is permissible to use up to 2400 or even more than that, 3600 or even more than 20.
Coming to the entacapone question also, entacapone has been used at higher doses as well. 200 mg is what you mentioned, but there have been studies which have used entacapone up to 2000 again, 2000 mg, etc., because of its effect in both ameliorating withdrawal and in terms of craving.
Yes, it has been used. Not exactly at this point of time, I do not remember the outcome of the higher dose study, but it has been used. I have done that was in literature.
Again,
I think one point
Yeah,
Saurav is mentioning that use of dronabinol for withdrawal symptom has been pretty okay. Actually, for the last couple of months, we're trying to get dronabinol, which is available at Merinol in India, and been used by oncologists for anti-nausea treatment. We hope we get some of those stuff and at least try using for the withdrawal symptom, which is like a agonist treatment, which is more sensible than other things. So that's and obviously Lekhan mentioned and Deepak mentioned, N-acetylcysteine is one thing probably would definitely encourage. With a few patients, we have very encouraging result, and it is easy to promote to the patients as a food supplement rather than as again organic food supplement. Then things so it's some should need more work to these things. But again, you don't expect drug company to push for this because these are all already out of patent, and I don't expect them to push it. But at least our experience should give an idea. And knowing N-acetylcysteine as a neuromodulator, I have a great hope in that.
Actually, N-acetylcysteine, one reason for this N-acetylcysteine also may be the mechanism. N-acetylcysteine targets the glutamate. One of the other commonly used drug targets, most of them, is this GABA and this other dopamine. N-acetylcysteine targets this glutaminergic pathways. So it may be effective.
So I think you are using quite a good number of N-acetylcysteine, correct, in our practice? I think it's a high time, probably sometime in next month. Can just small review on use of N-acetylcysteine. It doesn't really have to look at outcome. Doesn't matter what happens to them. But for the forum to understand and for us to give feedback to ourselves, we'll try next month sometime. We can collate and write a paper. We can definitely share with you our experience in N-acetylcysteine. And I think, as has been mentioned, Dr. Banerjee, Dr. Saurabh, you should definitely let us know what is your experience in practice using N-acetylcysteine. It is safe. One good thing is pretty safe stuff.
Dr. Banerjee is reporting that cannabis has been used in one patient.
Cannabis?
Marinol, dronabinol, has been used in cannabis dependence.
No. Banerjee, have you got access to that one? We are struggling to get dronabinol from, we are trying to get from pharmacy and oncology hospitals. Till now, we are not able to access it. In case you know how to access, you let us know so that we want to use ourselves for our patients. He mentioned that he got from the pharmacy in Bangalore. I will definitely let us know. We'll use it. It was very interesting. Very good.
In today's BBC News, there is a mention about the skunk cannabis, which they have made a hybrid from cannabis sativa and cannabis indica, which is supposed to have 3 to 4 times the level of THC and very low levels of cannabidol. THC is propsychotic and cannabidol is psychotic.
Oh, sorry. Okay, that's how virtual means. I thought somebody from outside. Thanks, Devanjan. I know you. So you should get some dronabinol for us.
Where would you put the main motivation syndrome in today's diagnosis?
Okay.
Motivation syndrome. Actually, a motivation syndrome. What is a motivation syndrome? We have to look into that. Studies have been very sparse in that regard, and mostly the motivation syndrome which has been thought to be due to chronic cannabis users who have significant cognitive dysfunction. So that they are there are some cases report that they are having negative symptoms of psychosis, but that looks unlikely, and most likely, as per current understanding of the subject goes, a motivation syndrome is a product of cognitive dysfunction due to chronic cannabis use.